Can you say something about the international policy that every home its own malaria pills?
Okay. I think you're talking about the HBMF, or the home-based management of fever strategy, sometimes also called the home-based management of malaria. And this is targeted to bring drugs closer to the community, to make anti-malarial drugs available in places where folks don't normally have access to health care. This has been advocated by the WHO on the basis of some research, and also has been adopted by a number of African countries, not all, but some. And the idea is to, in those villages where health facilities or clinics are not available, to bring drugs to a few designated people in the community. They call them community medicine distributors or community drug distributors. And if a mother has a sick child, she brings it to the community drug distributor or the community medicine distributor, and the antimalarials are available if they agree that the child needs treatment. Up to now, no diagnostics have been available. It's just presumptive treatment, but at least it has brought the drugs closer to children that may be ill. This has achieved one part of the general objective of bringing good health care closer to people, the HBMF strategy. However, since many cases, and in most parts of Africa, most cases of fever or illness, even in small children, are not actually due to malaria, it leads to gross overdiagnosis. On the one hand, it's a safe approach because it treats the malaria if it's there. Children are less likely to die. However, if the bulk of those cases are not actually malaria, we need to bring in a way for people to know what's malaria and what's not malaria so that they can improve the case management. And in that regard, new efforts to bring the diagnostic tests, for example, the rapid diagnostic tests, or RDTs, are very much welcomed by many stakeholders. Well, we've done a series of studies with RDTs, rapid diagnostic tests for malaria, in Uganda. And of course, this is complementary to the work of a lot of other research groups. But what we did is we started in Kampala, just one small cohort of children, and we found that certain of these tests are working quite well, quite accurately, to diagnose malaria, comparing to microscopy and even PCR molecular methods. We then moved into areas all around Uganda, because you can expect that diagnostic tests will work differently in different populations. We took 1,000 patients of all ages in 7 different regions of Uganda with the same tests. And again, we found a little bit differences in the properties in different areas, but in general, very encouraging results for the accuracy, the reliability of these tests in children and adults around Uganda. And then, as I was saying, then the main question is not now so much how good are the tests. We feel quite comfortable with certain types of these tests, but how can we get health workers who've never had access to a diagnostic test before to use the new RDTs appropriately in case management? So we designed a training program and piloted it, or did a study of it. We brought that training program and the RDTs to some of the health centers and brought it to the health workers. Now, they are starting to learn how to use which patients need the RDTs, what am I going to do with the positive result, what am I going to do with the negative result, which is the real challenge. And we got a very good impact in a short term. So now we are using that same training program in collaboration with the Ministry of Health and the Uganda Malaria Control Program to go out and introduce RDTs in health centers around Uganda and hopefully change not only the little bits of plastic that are the test, but the way the health workers are managing their patients. So we're getting some very encouraging results here in Uganda and as well in other countries from that introduction. So even in a small country like Uganda, we find that malaria transmission, and therefore the amount of patients presenting with malaria, varies dramatically from one part to another. For example, when we did our study at the 7 regions around Uganda, in some places we found only 4% of patients with malaria-like symptoms actually had parasites in their bloodstream. And you can contrast that with numbers from a high transmission region, again in Uganda, where for small children, 85% had parasites in their bloodstream, and for older patients, about 50%. So you can see that even in a small country, there's a very wide variety or wide variation in the proportion of patients who look like they have malaria but don't actually have parasites.
What's your opinion about the number of malaria suffering people? One says it's 250 million.
Yeah.
Do you agree?
One benefit that bringing diagnostics in will help with is also to know the amount of malaria that we actually have in different parts of the world. You might have heard numbers from the WHO and other major organizations, estimates of, say, 250 million cases per year or 1 million deaths. Now, those are the best estimates, but those are based only on presumptive diagnoses. When people give those numbers, we're not basing them on diagnostic tests. So we know that, for example, if only 4% or 50% of patients with fever actually have parasites, that the real numbers of cases are going to be lower. So the benefits of bringing in the diagnostic tests will both give us an accurate measure of how much malaria there is and help us to treat those patients who don't have malaria but may have something else serious in a more accurate and helpful way. I'm very encouraged by the trend of more and more major stakeholders and donors bringing in funding and efforts not only to bring anti-malarial drugs, which is one part of the equation, but also to bring in the diagnostic tools, because these two things together are what will really help us to improve the fight against malaria.